Yes, yeah, Dr. Thawee, I think I'm just sorry because in the morning like the meeting link was wrong, so I got the meeting link again. But I think today's the connection is I think the very poor, very bad, I guess.
Yeah, your sound is good. You sound good, but from Indonesia, the sound is not good.
Now it's better.
Yes. What about Dr. Thawee?
Yes, good. I think better. Image also better.
How's the picture?
Surabaya is is better
the
also.
Picture is good. Right now it's good.
Okay. I think we will start. Silakan anestesi. Okay. I think before we perform the ERCP, we will pray according to our religion and beliefness. I think we start to pray. Bismillahirrahmanirrahim. Pray is finished. Okay. Bismillah. Now me, Luthfi, Dr. Santo, and Dr. Numan, also the nurse behind me. Dr. Santo will read the case. Please, Dr. Santo.
Okay. This is the young woman, 32 years old, with chief complaint in pain in right upper quadrant with jaundice for 1 month. From the physical examination, Vita sign is within normal. We found the sclera is icteric and abdominal examination. We found the distended in abdomen and pain right upper quadrant, no mass and others normal. From laboratory, we found within normal and liver function test, total bilirubin 2.31. From alanine serum transaminase 40, alanine ALT 37, ALT 213, gamma GT 76, and the others normal. From MST abdomen before the ERCP, in 1st June, we found dilated intra and extra hepatic bile duct because of CBD stone. After we do the MRCP, the ERCP result, stone in proximal CBD, it's a large stone, about 1.3 centimeters.
Okay, I think we can start. The endoscopy camera not move, please, IT. Now we are at the antrum and go to the papilla, to the pylorus. Yeah, minor papilla. And you see the bile can throw out. Okay, we shortening and then try to get the best position to assessing the papilla. I think this one. Yeah, here it is. Okay. As I say yesterday, these patients already performed in first week on June, and now we will perform spyglass for the big stone. I think not really big. Okay. This is clear, yeah? Wire?
Yeah, it's good.
Okay.
That's good position. Yeah, very good. That's good.
Okay. Now we are, you see the fluoro view?
Move flow up a little bit. Move up a little bit.
Yeah, okay.
That's good. Yes.
Okay, we will go inside. I see contrast, injection contrast. Okay. You can see the fluoro. I see stone inside.
Yeah, I cannot see.
Maybe.
I cannot see any stone.
Yeah. I think spontaneously release. Fluoro, contrast. Ah. No stone.
Maybe you can more cut more symptomy and then use a balloon to sweep.
Okay, more sphincterotomy.
Yes.
How many mm?
You can see the suprapapillar. If you allow to me the co-host, I will make up for you at the.
Okay. Thank you. Angel, please. Bending. Enough?
Yes, good. A little bit more. Nah, that's okay. Good. Yes.
Okay. Try balloon.
Yeah, you can use balloon.
Pertahankan wire. Keep the wire inside. Do we have to switch to the wire to 35? I think this good. Okay. I think because we already performed on 6 June, maybe it's spontaneously release, but we'll see by using the balloon.
For the first ESP, you already passed 10, right? The first ESP.
No, not. Actually, this case no stent, just sphincterotomy before.
Oh, just sphincterotomy. Okay.
I think this is the maximal limit for us to cut the sphincter, Prof. Thawee?
No. If needed, you can cut more.
Oh.
If needed, you can see the super. You can see suprapapillary fold. If you let me to be co-host, I will make a mark for you to the maximum cut if needed. But in this patient, is no need to cut more because
we are with the balloon.
Yes.
Test the balloon first. Okay. I'm with the fluoro. Until here, enough? Balloon, please. Okay. You see the balloon? I think the size is too big. Decrease the size. Oh.
For the assistant, normally is a balloon just a little bit bigger than that, not much.
Yeah. Contrast. Okay, that's the balloon. Okay, we'll go down. Okay, I think it's clear. I will try one more. Entrance, entrance, entrance. Here? Balloon? No, not full. Okay. No need contrast. Okay. I think no more stone.
Good luck.
Yeah. Thank you. This is
first
our
case.
first case.
Good start.
No
good
more
start.
stone. I think it's.
If
you see the bile can go out. And I want to ask you about the size of limitation of the sphincterotom.
Let me to be co-host. I will mark for you.
Yeah. Just mark me. IT ini mau dimarker sama Prof Thawee di endoskopi. Tolong di.
Yes, good.
Okay, please marking.
Yeah, this the maximum. This the maximum. This area. You can see.
Okay.
So you can
That's
cut.
the fold.
Yeah, this the fold. Yes, this fold.
Okay. So we can cut until the fold.
Not beyond this area.
Okay. Good direction. Thank you very much. I think I will go out and we will prepare for the second case. Dr. Numan, any comment or from other center? You can ask about this case and the process. Okay.
Can I ask a question to Prof. Thawee?
Yes, please.
Yeah, Prof. Sometimes we have difficulties in doing the sphincterotom. I think that this case have a good direction of sphincterotom, but sometimes the direction is going to the right, not to the left. I mean, it's not going to the 11 o'clock, but it's sometimes going to the 1 o'clock. Especially if we do papillotomy, so we enter the main pancreatic duct and we want to do the papillotomy, and our direction is cannot go. How we direct to the good direction, Prof, to avoid the
three recommendation. The number one, you keep the ampulla at the lower half of the skin. The number two, you use your right hand to control the direction of the sphincterotom. You just right hand to hold the scope and you counterclockwise. The cutting wide view to the left to the 11 o'clock. And number three, you use true tome. Because true tome, you can rotate from 1 o'clock to 11 o'clock. Because this is a rotatable sphincterotom. My answer, the number one, keep ampulla in the lower half of the skin. Use the right hand to control by counterclockwise the cutting wide from the 1 o'clock to the 11 o'clock. The number three, you use true tome to rotate from the 1 o'clock to 11 o'clock. three options for you, depend on the case.
So, Prof, should we bend the true thumb when we do cutting?
Yes.
Okay.
I think in difficult situation, true thumb is really helpful in terms of the rotatable. Yeah. But anyway, if you encounter to try everything but difficult, you can cut only 50%. You can cut because if you cut only 50%, no bleeding. The bleeding of the vessel normally is upper half. You cut only 50% and you use a balloon to dilate. Additional. If direction is not good. That's another technique to minimize in terms of the bleeding.
Thank you, Prof.
Yeah. I want to ask you about the maximum size of the stones that can be released spontaneously to the duodenum.
No good answer for you. Lovely is if intact, ampulla, no previous symptomy, no 5 millimeter cut off, less than 5 millimeter in 4 weeks, the stone will spontaneous 20%. 20%. But if you cut as no the data for you, but sometimes we surprisingly, sometimes 1 cm, 1.2 cm, 1.3 cm, the stone also can spontaneous from the bile duct to the duodenum, especially in the elderly patient. In some elderly patient, you can see we call duodenocholdunostomy. You can see the ectopic hole just above ampulla. That means fistula. This fistula, what was cleared by the stone migration because the stone erode suprapapillary and spontaneous migration. So my answer is intact sphincter less than 5 millimeter in diameter, mostly spontaneous migration. But if more than 5 millimeter, when you make a sphinctomy, it's no any site to give you the idea. But sometimes surprisingly, even 1.5 sometimes spontaneous migration. So that means if you cannot perform the first one, adequate sphinctomy is very important. The second one, if you put stent in, the stone is smaller because it's good drainage, make a stone smaller. In this particular situation, you can keep the double pigtail maybe 2-3 months, and most of the stone is smaller. If you flap 3 months, in the literature, the stone smaller 4 to 9 millimeter in diameter. So if you cannot break anything, you is mechanical literature not available, spine not available, just put stent in, double pigtail, and adequate sphinctomy, and then 3 months you come back. Mostly stone is smaller, and you can make more easy to remove stone.
Greeting Dr. Thawee. This is teacher from Malang.
Yes, welcome.
Can I ask you some question, Dr. Thawee?
Yes, please.
Sometimes if we do ERCP with the history patient, the history is previously ERCP. Sometimes we cannot see clearly the ambulatory, so we difficult to cannulation. Is it any tips for that case, Dr. Thawee? Is it we perform the Burdick maneuver, or sometimes we perform, I don't know, maybe a double wire technique, or is there any tips from Dr. Thawee? Thank you.
Thank you. Good question. You mean you cannot find ampulla, or you find ampulla but you cannot cannulate?
Yes, yes, Dr. Thawee. Is there any tips for that case if the patient, the history previously uh, undergoing ERCP, so it's difficult to cannulation. Is there any tips?
So I think in next week I will release technique for cannulation in
Okay,
YouTube.
Dr. Thawee.
The
Okay,
next
thank you.
I short answer for you, but I recommend to see the YouTube. I will send to you next week.
Okay, okay, Dr. Thawee.
We already describe all the technique to cannulate in the bile duct from the basic to the advanced. My
Yes.
answer is the first one, you need to good position of the ampulla. Normally the good position ampulla in the right upper half of the skin. The second one, for endoscopy, you slowly to control the tip of ampulla, the tip of syndrome into the common channel. Just put the tip in the common channel. And number three, you preload the guide wire. You preload the guide wire in the syndrome and nurse slowly to insert the guide wire during endoscopy to keep the direction of the syndrome in uvenococ and vertical direction. And the nurse very slowly to manipulate the guide wire into. If you try anything, cannot, recommend to inject a little bit of contrast to see the direction of the bile duct. So I think you need to learn together with your assistant is very important.
Okay. You mean,
but,
yes?
But in some particular case, especially for the first fail cannulation, basically in the second attempt, more success, and anyway, if you cannot cannulate again, the solution is you pick up the dendrite. So you need to learn how to perform dendrite safely as well.
Okay, thank you, Dr. Thawee.
Prof. Thawee. Dr. Numan, Prof. Thawee. Makassar.
Yeah, please, Dr. Numan.
Yeah. If the case large stone and I not have spyglass, when to choice white sphincterotomy or FILVD?
The number one depend on the size of the CBD. Normally, if the size CBD, for example, the stone 1.3 and size CBD 1.5, and the CBD is a good shape. Good shape mean the latest CBD down to the ampulla. And the particular situation is you cut sphincter roughly 75%, and you use a C balloon 12 to 15 to dilate. We call EPLBD. And this is a good way to remove, because basically the stone more than 1 cm or 1.2 cm, only symptomy too difficult to remove stone. If you combine with the balloon dilation with the CE balloon, we call EPLBD. That's good. You can remove stone up to 1.5 cm. You can use combine.
Thank you, Prof.
Prof. Thawee.
If you let me, I will share my screen to you for the EPLBD. Please wait for a while. ต้องเปิดก่อนครับ
Because we are using the only one room, switch patients right now and prepare for the second patient. Maybe in 10 minutes, we will start with the second patient.
รู้แล้วแต่มันต้องเปิดสไลด์ไม่เปิดสไลด์มัน
Prof Thawee, little loudly, please.
So I will show you the my presentation.
Please.
You see screen. You see the screen?
Yeah.
Yes.
You can see the
Not
picture. You can see the picture on the right hand side. You can see.
Yeah.
On the right hand side, the shape of the bile duct is proper for EPLBD. You can see on the right hand side is a normal small CBD. It's not good for the EPLBD. From the left hand side is good one because dilated CBD down to ampulla. Please remember, please do not dilate normal CBD. Dilated CBD, not normal CBD. That's very important for the technique of the EPLBD. For the right hand side, if you dilate, CUA bleeding and perforation. So the left shape of the cholangiogram is very important for EPLBD.
Okay.
I will show you another presentation. Please wait.
Dr. Santo, Dr. Rhini, please, the second case. I think this topic is quite same with the case that I saw you last week. The distal is normal CBD, but I still try to dilate it, and it's not work actually.
You can see on my screen.
Yeah, I see.
I will show you the ampulla here. You can see the ampulla here.
Okay, clear.
You can see my PowerPoint.
Yeah.
Yeah, you can see the shape of ampulla is different. And direction of the bile duct conduction also different. So the third picture, the upper low is quite common, ampulla shape. The back arrow, that means the direction of the bile duct cannulation. You can see the bile duct cannulation is different, depend on the shape of ampulla and related diverticulum as well. Please wait for the next week. I will release the English version for the bile duct cannulation.
Yeah.
Thank you very much,
Very
Prof.
good direction. Yeah.
English version
So
is very
sometimes
important.
we are at the 12 to 1 o'clock, yeah? Just like in the 7 case, I think 12 to 1 o'clock. Is it with the short or long scope? Do you have any slide for the long scope, the direction for the long scope?
Normally, I will show you this one. This one. You can see this picture. Basically it's a long scope, especially for elderly patients. If the ampulla in the inferior duodenal flow in the duodenum. In this particular situation, is mostly we use a long scope position.
And the direction to the for the cannulation?
The same one. The direction is the same one. But you need put the scope down as a long scope position. You can see this picture is if the ampulla in the standard, the middle of the descending duodenum, the scope is a short one. But the location is inferior duodenal angle. You need to put a long scope position. Or also for the minor cannula, minor cannulation also sometimes long position as well. For the minor PD.
I think in the second case we will use spyglass, so just prepare. Okay. Dr. Santo will present the third case. I think the slide, please. Teman anestesi barangkali kita bisa mulai.
Okay, this is the second case. 54 years old female, which complained pain in right upper quadrant with jaundice for 2 months. From the physical examination, we found the vital sign within normal. On the sclera, we found the icteric. And from the abdominal, we found pain in right upper quadrant, no mass, and the others normal. From laboratory, we found the complete blood cell within normal, liver function test within normal. From CT scan abdomen, we found the gallbladder and SpPD stone, the size 1.62 times 0.62 times 1.77 centimeter. We already do the ERCP. We found the CBD was dilated with a balloon dilator to a pressure of 50 atm until 1.1 centimeter. You can see the CT scan. Next slide.
Yes.
This is the CT scan. We found the gallbladder stone and SpPD stone before we are do the ERCP. Next slide. This is the ERCP. Any comment, Prof. Thawee?
No, we need to see the real image first, and then discuss later on. So, what the size of the common bile duct from the CT scan?
From the CT scan, next slide, please. Next slide. This is the stone size.
The size of the bile duct.
Bile duct. The radiology didn't expand the bile duct size.
Because the size bile duct really important. Why? Because you can see the stone is a 1.6 by 1.7. But if the bile duct is maybe 1.5, that means very difficult. Because there's no space for the mechanolithotiter. But good for spine. But if you spine not variable, mechanolithotiter is difficult. And also difficult for the EPLBD as well. But if the size bile duct 1.8 is very good for EPLBD.
Prof, can
Yes.
I ask?
Yes, please.
If we have several stones, which stone we need to use the mechanical lithotripter, which stone we take first the lowest or the highest one?
Basically, it's a lower one first. Basically, lower one first. But sometimes lower one difficult because no space to open the basket. And that particular situation, you break upper one first to make a more room for the lower one. So my answer, try to lower one first. If lower one difficult in terms of no space, you try upper one first. And when you break the upper one, more space to move stone in the lower one up, and you can more space to cap the stone.
Yeah, we will start with the second case. Because
Yes,
we
please.
only have one scope. And time to clean about 15 to 20 minutes by machine. Dr. Numan, please.
Maybe equip the director buy one more scope. Huh?
Yeah, that's right.
Okay. Hello, Prof. Thawee.
Yeah, Dr. Numan will perform.
Coba lagi. Belum. Sepanjang lah. Oke. Ya. Okay.
Inserting the scope. Yeah.
That's very good. Very good.
Yeah, it's fibrous,
Satu duodenum,
bulbous,
di situ ampula. Tidak ada. Bentar, Pi.
This is the ampulla. Already performed the RCP2. This 1.7, I think. 160.
The first ESP no stent, right? Or you paste stent?
As I remember, I think just already put the stent. Probably it's migrate to the distal because in the fluoro we cannot see also the stent.
Mm.
We will double check with the fluoro after.
Okay. Okay.
Okay. Fluoro. Oh, I will. More contrast. More contrast.
Move follow to the right of the patient. Yeah, put the white in because yes.
Yang di balik scope.
The wire first.
Put the white in the intrahepatic duct.
Harus wire turun dulu, taruh wire. Okay, turun wire.
Okay. The wire will be pulled back, yeah, and then try to.
I think it's a wire in the
go
sitting
up
duct.
again. Yeah, the wire in the cystic duct. So pull back and tarik kembali, pull back, and try to rotate to the left side.
Oke, ya, naik, naik kembali tuh. Ya, naik.
Yeah, that's good.
Oh,
it's okay. Pull back a little bit the wire and push the. Yeah.
Kontras.
Kontras.
It's good.
Posisi wire dipertahankan. Saya turun. Oke. Kontras. Kontras.
Any comment, Dr. Thawee?
Right now, I cannot see the collector clearly. We need to see the stone first.
Okay.
Yeah, more contrast, more contrast.
Okay, coba ini.
Yeah.
Stone.
I think you can see the stone.
Right now, we can see the stone. Okay.
Yeah.
And then
above the scope.
Yeah. And then we need to see the distal bile duct.
Yeah. Distal. So pull back the spring.
Nggak bisa muncul situ. Oke.
Okay, here. Dia mau lihat ukuran cystic duct yang di distal. I think we cannot see the distal side because contrast go down, go out.
Yeah.
Go out.
So I think this particular case, EPLBD is a good option for you.
EPLBD, okay.
Yes.
Firstly,
you can cut sphincter more, and then you can use a C balloon 12-15.
Yeah, cut more.
I think you can, and then you can remove stone.
Baru kita ganti wire ya. Swing dulu. Okay, I will to start sphincterotomy, and then I used sphincteroplasty.
If you check skin, I will mark for you for the upper part that you can cut in this particular case.
Okay.
Please mark.
In this particular case, you cut here, cut up here. The up here is maybe 60-70%, and then use a say balloon. Cut here, allow this area. Both a little bit. Yes.
Yeah.
A little bit more, and put the cutter down. Put the cutter down. Put the cutter down.
More.
A little bit more.
Bengkok sedikit ya. Bending. Okay, of course.
If you put the cutter down, you can cut more effectively. Yes, like this. Yes, and both swing the thumb. And yeah, and rotate to the left and cut slowly.
Slowly ya, ya. Oke. Ini posisinya.
The problem right now is the position of the blood is not stable. Try to keep a stable position first.
Open. Okay.
Yes, and you just use your right hand to control the scope and slowly cut. Put scope in. Try to keep it in stable position first. That's very important. Right lock, clockwise, pull back again. If you're facing difficulty, maybe use a long route. If you find difficulty.
Yeah, very difficult. the posisi sphincterotom.
Yeah, and then big book up.
Actually, in the first ERCP, we already perform sphincteroplasty. So it's makes us easy to cannulate today. But the position, this is the obese patient with the semi-prone position, quite hard to make the position of the scope stable.
Yeah. Bo synchrotome. Bo. Pull back synchrotome. Pull back a little bit. And then slowly cut. Slowly.
Yeah. We are using Olympus scope with the ESG 400 for the.
You said how? What setting? What your setting?
The power, I think 120.
120. And how cast right?
40, yeah. 40. I think this is a little bit low.
Oh.
Okay, that's enough.
I think as if encounter difficulty, you can delete and you cut later on. You can use a say balloon 12-15.
And then okay. Okay, ganti wayarnya itu.
As in the fluoro, the contrast cannot go down, but in the distal, it's clear for the contrast. I think the stone in the top of SpPD.
Change wire ya. 35. Okay.
Dr. Roman changed the wire to the 35, 3.5. We are using the balloon for APLBD. I think we need the sticky wire, and 35 is good. How do you think, Prof. Thawee?
Yes, right.
Yeah. Yeah.
What is your suggestion about the size of EPLBD?
In this particular case, it's 12-15.
12-15.
Yeah, CAE balloon.
Ana.
Actually, the Boston just prepared for us 8 to 10.
8 to 10 is too small, I think.
Okay, we try with the 8 to 10.
Santo, posisi. Ya, turun ke bawah. Oke, cukup. Ya. Now to start to balloon duration.
So in this particular case, if you use balloon 8 to 10, basically you need trapezoid to break the stone. I think so in this particular case, more space easily to use a trapezoid to break and remove.
Be first, even just with the 10, and after that, try balloon or basket.
No, trapezoid.
Okay. In endoscopy view, you can see balloon inside the ampulla.
also can see the mark. And slowly insert. Yeah. Slowly insert. Okay.
Yes,
I
that's
think
good.
that's the marking.
Yes. Yes.
Good.
Yes, very good.
Okay,
Yes.
contrast, please.
Yes.
Okay.
Yeah, that's good position. Slowly in fade, slowly in fade.
Slowly. Jangan terlalu. Ya.
2.5, we will increase the pressure until 9 until 9. It's 9 milli.
Yes, you keep for 1 minute.
Okay.
Do you have tepisoy?
Kunci boleh,
Prof. Thawee.
kunci.
Yes, please.
With the sphincteroplasty, it mentioned that it has a risk of pancreatitis. Is it something that we have to concern about this pancreatitis in the sphincteroplasty?
Yes, but basically for the EPLBD, you cut sphincter first. When you cut sphincter, the opening of the PD is going down, and you dilate is list of the pancreatitis very less compared with the without syncrotomy. So for the technique EPLBD, you need to cut sphincter first, and then you dilate later on to minimize in terms of the post-ERCP pancreatitis. So that's why we cut roughly is 20 to 25%.
3 minutes or 5 minutes.
Okay.
Dilated.
We can delete right now.
So after dilatation, is 2 options for you. The first, very easily, good option, you use tepisoy to break and remove stone very easily. And if tepisoy not available, the second option is to put spike in to break stone, because stone is 1.6 bigger than you dilate the sphincter. You cannot use the standard basket. If you use standard basket,
Okay.
you will encounter the problem of the basket entrapment. So you need micrototator is tepisoy is good.
Okay.
I think
Balloon
we will
deflate.
prepare basket.
Okay. Deflate.
First, deflate the balloon.
Prof, do you
Yes,
suggest use trapezoid with wire or without wire? And
in this particular cases, without wire, you just put alongside the wire. No need over wire.
oh, why? Is it because the stone deep?
No, because the stone in the location is not difficult. We normally we use over wire if the stone in location is a difficult area. But very easily you just put the tepisoy alongside the guide.
Okay.
So in this case, we will use over guide wire or not over the guide wire, Prof?
Basically, no, not over the guide wire. But for beginner, maybe use over the guide wire more easily. If you're not familiar with the tepisoy, yeah. Because tepisoy, the advantage is wire guided basket. If you're not familiar, you can use over wire. But if you're more familiar with the basket, you in this particular case, no need. You just put alongside.
Pantasan scope saya lari terus ke sana pasiennya bingung. Halo.
I thought when we use trapezoid over guide wire, it will be safer, Prof.
Might be safer, but if you're more familiar, it's no different.
Okay.
Now we enter the
Basket.
Keep up. No, pull back trapezoid, pull back a little bit, pull back and pace later, and then big move up, pull back a little bit. Yeah, and put scope in slowly. Put scope in very slowly. No, try again. Yeah, very slowly, yes. Maybe pull back again, pull back and try to put the tip of the trapezoid at the apex that you already cut at the apex. No, pull back again, pull back first. Pull back cutter first. Yeah, put the apex and then so this one you put the cutter in the apex. Yeah, this one. Yeah. Put the cutter in this area.
Put.
You feed the picture. I will show you. Move the trapezoid back first. Pull back first. Remove trapezoid first. Pull back first. Okay. You can see this picture. This is the good location to tip trapezoid here. Not here. Not here. This you put the tip trapezoid here and big view up. Put the tip trapezoid here and big view up. When you big view up, the tip trapezoid inside the bile.
Okay.
Pull back first. Yes, try again. Yes, the tip. Yeah, very good. Feed. Yeah. Pull back scope a little bit. Feed. Yes, this, yeah. And put the scope in. Slowly put the scope in. Put the scope in. Put the scope in slowly. And put the trapezoid parallel with the bile duct. Slowly. If cannot, no problem. If cannot, you can insert spine over the guide Y and break with the HL. Because spine over Y is very easily.
Kenapa pakai wire ya?
Keep the Y.
No.
Keep the Y and then remove trapezoid. And you can insert spine over the Y.
Yes, while waiting, can I ask question? Oh, it's already started. Okay, I will.
sedikit ya.
And then when OY, you can use the control with the up down of the spine to bend the spine up and more easily to go in. Yes. Bend the tip, the scope up, yeah. The spine scope up. Yeah. And then you insert as a stent, same in the stent. Right now, you very important to keep in stable position. If not stable, the scope will slip out. More cockwise, more keep cockwise. And big wheel up, and big wheel up. Yeah, and then insert the scope up to the close to the hilum. Because this OY technique, you can insert over the Y.
Yeah.
You can see it's more cockwise because in this position, scope might be slip out. Put the scope in. And you can adjust the tip of the spine to see the luminal view of the CBD. I think I put scope a little bit in.
Ini kan posisi back.
If you insert spine as when you put a 10 fence stent, the same feeling. Put scope in more.
Coba kasih audionya Prof. Coba. Ya.
Be careful, slip out. Huh?
Okay. Iya. Iya. Ya.
I think put.
Oh.
You can see it's slip out. Yeah. So that's why you need to put scope down. Pull back the spine scope first. Pull back first. Pull back slowly. Pull back, and back the KY to state the Y. Yeah, to state the Y again. Yes, good. And try again. To see follow to make sure Y in the intrahepatic duct, and try again. I think it is good position right now.
Okay.
Yeah, try again. Yes, and big wheel up. Light lock cock way, big wheel up. Put the scope down. And big wheel up. And you can see the spine inside. Put the spine inside deeply first. Yeah, more and more. Yes. Same when you put a stent. Yes, more and more. Up, more.
That's only for shell, yeah? Dirty,
Yeah.
You put the scope more, put the scope down more. Put ESP scope more, deeper.
Okay.
Yeah, more deeper, more deeper. Be careful, slip out again. Be careful, very be careful. Huh?
Okay. Okay. Oh, out.
Or you keep the patient in the left lateral position. Put ESP scope down and big you up. Put a little bit more down. And big you up, big you up. And pull back wide a little bit. Pull back wide a little bit, big you up to insert scope deeply. Lấy nào về cây hoài, về cây hoài.
Okay.
How if we remove the wire? Thawee?
Yes.
How it seems like the wire resist the move of the spine.
No. Normally you keep the wire in, and when the doctor puts a spine, same when you put a stent, the assistant will stent to pull back the wire to make a strengthening the wire. Same when you insert the PD stent, CPD stent, the same maneuver. The same maneuver when you put a stent in.
Okay.
When you put in, the nurse will pull back. Yeah, pull back wire a little bit. You put in, back. Same when you put the 10 French stent. The guy wire right now in the therapeutic duct, yeah, right?
You see in the fluoro?
Not clearly seen. Yeah, right now supply inside, right?
Yeah.
That's really good. And then you adjust the spine scope to keep the luminol in the center.
Okay, perbaiki dulu.
And to see the stone.
Okay. Yeah. Okay.
You can see stone. And
yeah.
Then you can remove the KY.
Remove that wire.
Yeah. And then you connect with the irrigation system and prepare for the ESL.
Irrigation system already.
You prepare ESL or laser.
Now we put the
Fiber laser.
fiber laser.
What the size of the laser fiber? 200 or 300?
365.
Yes, 365 you try to put in. Sometimes difficult, but you can tie first. You can put the laser fiber inside the spine. Before you try, you need to sharpening the tip of the, can you see the laser fiber?
Yeah.
Terus. Keluar apa? Okay.
This is the laser fiber, right? Yeah. Pull back slowly. You can see laser fiber. Yes. You can see laser fiber on the 6 o'clock. Yes.
On the 6 o'clock. Okay.
Yeah. And then right now, you need adjust the up. You need to adjust the laser fiber up by moving.
Okay.
What the setting? What the setting that you use right now?
No.
10 watts.
Normally we use setting. You can use the frequency is 8 to 10 frequency, and the power maybe you use 2000 or 2 June.
Energy pulse 0.5.
I think 0.5 is.
Yeah, 0.5.
Okay, you can type first and then see later on. So early can system is really important. You need to make a clear view. Really important. You need to make a clear view. Really important. And keep in the stable. Yeah, really.
Okay. Ready?
Okay, and keep the tip 1 to 2 millimeter from the stone. Yeah, and then you can fire.
Okay. Yeah.
And yes, early case system is very important. And you can fire.
Okay.
Yeah, water irrigation.
More water.
No, slowly. You need to see, minimize the perforation. You need to see the stone and the tip of spine first before you fire.
Yeah. Tundukkan.
Yeah, pull back a laser a little bit. It's too long. The tip too far. And yeah. Okay, try again. Up. To adjust the tip of the scope. Put the more water in, slowly more water in. Can I see the monitor of the laser?
Okay.
Yes, try fire. Try. I think this is a little too far. Yeah, close. Maybe adjust this too far. This too far. I think. Yes. Fire. Pull back a little bit. Yes. More. Pull back. Laser fiber a little bit. Yes. Fire. More. Put in a little bit. Yes. Fire. More.
Okay.
Put in more a little bit. Put the fiber in. Yes. Good version. Yeah. Put the fiber in. Yeah. Good version and fire. I think let me see the screen. I think the power is not enough.
Ya, oke. Oh.
Normally, I use two joule. 2 joule mean 2000 watt.
Tarik keluar sedikit. Agar oke.
I think the power is not enough.
1.2.
No, up to 2. You said 2. And frequency maybe 10, 8 to 10. Frequency.
Now it's 2.
Yeah, yes. Yes. And then water election is very important.
Yes. Water.
So assistant maybe use the election port to suck the water out. You can see in the spine, election port can suck out. Use the 20 mil saline to suck out. The view is more clearly.
Tarik sedikit.
Already call Dada? Call Dada, nah? Huh? Ask Kakak already can call Dada or not? Oh, why? Try again.
Jangan semprot dulu. Stop air.
Yeah, good position.
Belum pas tengah.
Yes, good position. Yeah, very good. That's good position. To break stone, yes. This very good position.
Otomatis.
Very nice.
Robek. Oke. Iya.
Yes, fire. Clear view is very important to minimize in terms of the perforation. Yeah, and effective, yes. Before you fire, you need to clear view first, yes.
Ya.
And you fire and you're waiting for the clear view and fire again. If the not clear view, you just allocate to suck the water out and fill the more water in the pump and then aspirate with the saline.
Ini sudah pecah. Fragmented. stone?
Yes, some stone fragmented. Basically, this size of the stone is basically things not more than half an hour.
Oh, okay.
So all the spike case, you need to keep proper prior antibiotic to minimize in terms of the cholangitis. And the volume of the irrigations are not too much.
Okay. Yeah. Good. Good.
Yeah. What nak?
Okay. Good. Benar.
You can see the shape of stone is not normally should make the stone one stone to fragmentation, but in this particular situation it's not fragmentation. Smaller but not fragmentation. Normally fragmentation is easily to remove later on.
So it's what should we do now?
I think depend on the power of the laser and setting. This 20 watt or 30 watt of the machine.
Berapa?
2 kilo or 3 kilo. And pull back the laser and manipulate up and fill the bottle in. Yes, good. That's really good. A little bit more up, and then yeah, you can adjust the.
Mempengaruhi kak? Enggak. Ini turun. Nah, oke, dulu ya. Oke. Oh. Kenapa ini tema ini? Okay.
It looks smaller, right?
Yeah.
Masuk ya. Ya.
I think it looks smaller. In this particular situation, maybe if you cut more sphincter, you can remove stone.
Intrahepatik tuh. Oke. Oke. Masuk sedikit ya. Oh, oke. No stone here. Okay, go back.
We pull back, yeah, and more sphincterotomy, and then using,
yeah, you can remove stone, I think. You can remove the laser. I put the wire in, and then remove the spy scope.
Dari sini. Tiga lima ya. Nih, sini. Dependent operator. Dependent operator. Oke. CBD saya sudah mati. CBD saya mati. Oke. Nah. Peluru. Berarti dia harus mundur ini. Tunggu dulu deh. Oke. Peluru mana? Sudah. Deh. Oke. Kita santo. Oke. Masih? Sudah cukup ya. Coba. Back. Peluru. Kasih masuk ya. Kasih masuk ya. Saya turun. Oke. Dorong ya. Oke. Karena dia mengikut. Tuh. Apa? Kop. Oke. Nah. Sudah keluar. Nah. Dulu. Enggak usah mendorong ya. Oke, cukup. Lepas nih. Ya. Benar. Selamat datang, Lumen. Oke. Ya. Fluoro. Oke, posisi wire. Kasih sedikit ya. Balon?
Ya, balon.
Retrieval.
So right now we prepare for the using of balloon retriever.
Yes.
Dr. Numan will directly using the retriever. Even though Prof. Thawee firstly recommend to more sphincteroplasty, but first I think he will try using the balloon retriever.
Yes, yes.
If any question from the participant, please directly ask. Dr. Azaki, Dr. Masrul, Dr. Sinta, Dr. Siva.
Kasih panjang-panjang tarik. Ya. Nah, oke. Sedikit. Oke. Balon bisa.
We are using the Boston balloon. Diameter? This is 12, 9 to 12. Is it good enough the size, Dr. Thawee?
I think the side balloon depend on the bioduct. This is a big bioduct. In this particular case, I used at least 12 to 15.
12 to 15.
Yeah.
Balon?
Just ready here 9 to 12.
Balon. Sudah di kontras. Balon.
I think next time Boston will prepare more.
Ya. Oke. Kontras.
The balloon is not work. I think. Oh yeah, here it is. Ada. Okay.
Deflate balon.
Try more.
Kempes.
Deflate and insert again. More up. More.
Inject contact to see the bioduct first and then blow the balloon.
Okay. Kontras first.
Balon sudah nih.
Kontras first.
Oke. Fluoro. Oke, kontras. Oke. Kontras. Iya ngomong. Oke.
I think the size of the balloon is very small.
Yeah, too small. I think too small. Huh?
Yeah. Use another. I will have another, but different brand. Sorry.
Deflate. Change. Balon. Kasih color. Kasih color dulu. Wire mau keluar ganti ini. Oke. Balon mau diganti jadi keluar. Okay.
We will change the balloon.
Pakai aja. Ya. Oke.
The size of ERCP room about 4 to 4 meter. Quite small, but it's okay. What is your opinion about the size of the CBD? Because this is big, very big.
Yeah, I think CBD
stone,
at least 18 millimeter diameter. You can see the diameter of scope. Diameter scope is close to the 12.5. Maybe CBD allow maybe 18.
Mana? Oke. Apa tuh? Yang itu. Ya.
we are using 9 to 15 balloon.
Terus masih panjang terus aja belum masih panjang tidak pasti yang penting jangan mesti
Oke.
terus
18
terus kenapa dek mau pakai suction silakan pakai aja ya pelan-pelan menarik ini teh tidak melihat ini. Hah? Tuh. Nah.
Dia minta yang 18.
Nggak ada 18 kita. Hah? Ada. 15 50 gitu punya.
Oke.
Hah? Ada enggak? Ada. Ada. Ada.
Okay. The balloon insert little bit more.
Oke, posisinya cukup. Ini sudah sampai di setting di sisi dah. HD.
Okay.
Balon.
Inflate.
Itu kalau batunya tuh. Kontra. Oke, floro. 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 Ya, ini dia.
Yeah, I think this only sludge. Okay.
Fragmented.
Fragment, I think. Wow.
Try again. Yeah.
Try again.
Declare. Kasih kontes. Oh, naik lagi. Oke. Oke. Floro. Floro. Oke. Ya. Plate. Invite. Balon.
Okay. And then you keep the Y. You keep the Y and use a basket.
Basket.
Yes. Keep the Y. Keep the Y. Keep Y in place and remove the balloon because right now you cannot. Right now it's no more stone, right? When you make the balloon retrieve, and you keep the Y and put the basket inside, and try to clean with the basket again.
Di sampingnya saja, enggak usah dikasih masuk.
Iya.
Mana, Pi? Ya, kasih masuk seperti tadi ya, coba. Kayak masuk seperti di samping. Ada tadi di situ. Cupingnya yang hilang. Atau langsung masuk saja di sampingnya. Oke, coba bedeng ya. Kita bisa. Tadi posisinya harusnya gini, di atas gitu, toh? Dia maunya gini. Ada posisi yang baru. Oke.
This step is all right. I think you can use a regular standard basket. Might be a little bit more easy.
Okay.
Standard basket.
You put the technique to insert trapezoid. You keep the tip You come back. I will show you the.
Ini.
You put a tip at the apex that you already cut up a little bit high up. You paste better high up.
Tunggu. Oke.
More. No, not put in. Just big view up, slowly big view up, and put the scope in, and put the catheter in parallel with the technique to insert the trapezoid inside. Use a big view up, not put the catheter in.
Terus tahu juga. Oke, ini kan up ya. Oke.
No, too low.
Tunggu. Susah ini. Ya. Enggak, ini posisi ini kan harusnya.
Yeah, big up. Up, big up. Fully up.
Ya.
Yeah, fully up, and then put the catheter in and put scope in. Put the scope in and put it in the same parallel. And
Bisa sih kalau enggak dilihat. Tuh.
yes, good. And big up, fully up, and then put the catheter in and put scope in, and put the catheter, put the scope, put the catheter, put the scope in parallel. Yeah, yes, and put the catheter in slowly. And assistant put the scope in the same time. More. Put the catheter in, put the scope in.
Keluar.
Yeah. Slowly. Yes, slowly. No resistance. Put the scope in. Slowly. Yeah, can go in. Yes. Slowly. No resistance at all. If resistance perforation, no resistance.
Nah, ini Pak. Peristaltik ini.
I think it cannot change to the standard basket. More easy.
Ada itu di atas aja. Abis nih. Baru-baru ini lagi harus selesai. Kayak sini. Oh. Misalnya begitu ketagihan itu pizza.
No, cannot.
Keluar sih.
No, cannot.
Iya. Resisten sekali gitu.
Yeah, if resistance remove trapezoid out. Change with the dormier basket or spiral basket.
We have very limited basket. We have limited basket.
Do you have basket? No basket?
Try another basket.
Oh. Dorong. Dorong. Ya. Oke, hook.
The purpose of the use of basket to remove small fragmentation that balloon cannot remove. So normally it's after you make a breaking stone, you need to clean up the final with the basket, not balloon. Balloon just make a complete cholangiogram. Yes. Because this standard basket more easily because yeah, and then big up. Yes, and then put in slowly, big up more. Yes. Right now the basket go in and put a scope a little bit. Yes. Yes, go in easily. Yes. And then you open the basket inside the not the septic duct. Okay, good.
Mundur.
And then you open and then you irrigation. No, put the basket in first.
Oh. Okay.
And fully open the basket.
Okay, fully open
already.
And then you use a saline to irrigation and the basket and pull back slowly. You pull back to remove fragmented of stone.
Okay.
Yes. Irrigation and checking and pull back basket slowly.
Floro.
Okay. Yeah, pull back. Floro. Checking, pull back. Yes. This is the technique to irrigation to remove small fragmentation of stone.
Okay. Okay.
Okay, go in again.
Yeah, you can see no more stone. And then you can make complete cholangiogram and finish.
Finish. Okay.
Masuk kali.
Make pardon.
Kali lagi.
Yeah, you can find out with the complete cholangiogram. Occluded cholangiogram. The final picture. Use a balloon. Yeah, use a balloon for final good cholangiogram, the final one.
Balon.
Yeah.
Kasih balon untuk ambil gambar. Untuk tutup di distal.
Because the occluded cholangiogram, the final picture is really important for the patient.
Okay. Terus. Ya, ya gitu. Ya, ke atas. Ya, minimal lurus.
Tertahan di situ.
Oke.
Tertahan di situ.
Oke, tarik. Tarik. Ya, oke. Ya, udah terus nih kamu.
We insert the balloon right now to occlude in the distal and then insert the contrast for the final picture.
Yes.
In this case.
Kita ke atas dulu, ambil supaya sampai kontras. Kita full. Lagi. Lagi balon dulu baru kontras. So, nanti kita tutup pas sampai di distal nanti kita pertahankan balon. Floro. Oke. Ya, balon. Full ya. Ya, kontras. Siapkan kontras lagi. Oke, kontras. Ya, oke. Floro. Kontras. Floro.
Slowly, move
Kontras.
slowly. Yeah, yes, very good.
Ya, slowly, bro. Oke. Kontras.
Take and take a picture. Yes, good. Slowly. That's very good. Very good. You can see this balloon. Very good.
Kontras. Oke.
I'm not sure for this area. Fish follow.
Floro.
Yeah, you can see this picture.
Okay.
Floro, please.
Kontras.
Maybe one more time to check.
Floro, picture. Okay.
What?
The balon the distal, yeah.
Yes.
Now balon in the distal.
Okay.
That's good enough.
Oh, I think okay. Okay, very good.
Floro.
Mark him, please.
Yes.
What's on marking?
Jangan terlalu banyak gongnya. Tidak atas tidak ini. Itu fragmen sebelah sini, sebelah sana.
I think the fragment in the top ya. Dorong balonnya masuk ke dalam.
Tunggu, sebentar dia mau ambil.
How do you think about this case? Should we put the balloon inside again?
Yes. Try one more time.
Pardon?
One more time.
One more time. Okay, one
Yes.
more time.
And put the balloon in the Therapeutic and pull back slowly. Yes.
Yeah. Floro.
More. Up more.
Floro. Okay.
More up. Okay. Can you enlarge the follow view?
Floro. Ya. Sudah tidak bisa masuk.
This is the maximum size.
Okay. And then inject contrast.
Kontras dulu.
Balon.
Kontras dulu.
And then balloon.
Balon.
No, it's a balloon too low. More defect. Balloon first. Put the balloon high up first.
Ya, kasih kempes dulu sedikit.
Defect balloon.
Floro.
Put the balloon in. Put the balloon in.
Ya.
Balloon up. More balloon.
Floro. Okay.
And pull back slowly. Yeah.
Balon. Okay, balon. Balon.
Can have because my follow is too small. Can have the big one in my skin.
Floro. Okay. Okay.
Can you make the full screen for the fluoroscopy? The fluoroscopy.
Yes, good.
Okay. Ganti.
Yeah, contrast small slowly. You pull back balloon very slowly and make good cholangiogram first. Yeah, and blow balloon. And pull back slowly, very slowly. No more stone, right? That's very good.
Okay.
I think
yes, good. I think congratulations, Dr. Numan and team. Really good.
Yeah. Thank you, Prof.
Yeah, great work.
Okay. Thank you, Prof.
So please share my screen. I will show you how to set up the laser.
Yeah.
I will show you the setup of the laser.
Set up the laser. The laser, please. The setup of the laser.
Untuk pasien berikutnya mungkin.
Ya,
Ada tuh orang laser ini suruh kok anu.
You can see on the screen. Dr. Luthfi, you can see the skin.
Yeah, clearly.
You can see 8 to 10 hertz is a frequency, and 1.8 to 2 joule. This is a power for the laser. At least, in some machine you can more 2.2 or 2.3 joule to break stone. This is a setting for the laser.
Before we are using 2.5 and 10 hertz. Yeah, before we using 2.5 and 10 joules.
Yeah.
Luar. Keren dengan tangan bergetar. Foto dulu.
What time to prepare the case, next case?
Dr. Lucy, we cannot hear you. I think you're the mute. Dr. Lucy, we cannot hear you.
Oh yeah, now it's okay.
Now it's okay?
Yes.
Yeah. We have more patient,
Yes,
but we need time to clean the scope. It's take time about 20 minutes.
Okay.
I hope Prof. Thawee still have time for us.
Yes, yes, okay. So I will be back in next 20 minutes, right?
Yeah, we back
Yes,
in
okay.
next 20 minutes. Yeah, have a rest.
Yeah, we may have some break, bio break as well. Dr. Thawee, yeah.
Yes, yes, okay.
You may just drink some water. I think you may need some water. Please.
Not water, Achan need coffee, right, Achan?
I think we will start with the third case. Prof. Thawee and all of the participants. Now we have the big stones according to the MRCP. The size is 2.5. We will see the fluoroscopy first. Could you please to close the door? Okay. You see the stand inside?
Yes. Wrong stand.
Yeah. And the big stone, I think. The black one.
Yeah.
Dr. Numan will please
Basically, it's a
present,
little opaque stone is a hard stone.
So, firstly, if we entrance,
So this one is a hard stone, Prof.
Yes, right. Because a little opaque stone, normally hard stone.
ya relax Pak ya, relax.
Nanti kalau disuruh baca-baca ya.
But the good one, if you have a ES-L, that's really good. You can break with ES-L.
Yeah, ESWL.
Yes.
Actually, we have, but morally operate by the urologist.
Yeah. But the same technique.
The same technique, yeah.
How about the risk of bile duct injury with ESVL, Prof?
Really, really low. Really safe. Really safe, yeah.
Takut.
Normally, it's mostly we use for break PD stone. But sometimes we can break in-type duct stone as well.
We are at the bulbous right now. And yeah, I try to shortening the scope.
Yes.
Oh, I think stand migration.
Inside, yeah.
You can see the stand. Migrate to the proximal, I think. Here it is. And no, this is not tip of the stand here. It's migrate. How do you think? What is the planning of this case?
Yeah, just cannulate first and then make craniogram to see this distal end. And mostly can remove stent with the balloon.
Balloon. I think here. Okay. Wire. Okay. You see the position?
Yeah, not too high. Yes, good. The stent is
so,
yes, that's really good.
To remove the migrating stent.
Right. Remove stent first.
Remove stent first. So I switch.
Yes.
Do I need to inject contrast before?
Contrast first. Contrast first.
Contrast first. Okay.
To check the distal bile duct.
Contrast first.
Contrast. Contrast.
Contrast injection. Oh.
Contrast.
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 I think the size of the stone is bigger than.
Yeah, fix with the bile duct.
Yeah.
Contrast.
Maybe due to the stent.
Contrast.
Yeah. Okay.
Habis contrast.
I will inject contrast on the proximal side of the stone. More contrast, please.
So I think in this particular situation, you can break stone first.
Pardon?
Because I think the stone is fixed for the bile duct, right?
Yeah.
Yeah. And this stone fixed the bile duct, you can put a spy to break stone first and then remove stent later on.
Oh, okay. Right. We prepare for the spyglass.
Yeah, prepare spyglass.
Ya, biarkan saja. Pertahankan. No need dilatation.
Normally I will dilate later on. Yes, need to dilate. Yes.
Need to dilate later. After breaking the stone.
Yes. Because if you too much dilate first, is the water not remaining in the bile duct. Difficult.
Yeah, right. Agree. Okay.
Setelah ini baru kelihatan.
No. Spy right now. Yeah, spy first.
Setelah itu baru kita
We will break the stone first. I think that's good idea to avoid dilatation before crushing the stone because the water will not be remain inside.
Okay, teman.
I insert the spike. Okay. Okay. I will push about to Amelia or 3 milli. And then get the position. I think this is good position. And okay.
And big view up. Yes, go in. Already go in, yes.
I will see the fluoro. I see.
Yeah, very good.
Can we?
And then you can remove the wire and put the laser on.
Okay. I think we are in the distal of the stone.
Yes, yes.
Okay. No, I'm not going to use the scope right now. I am going down to the SPY.
The SPY, yes.
Yeah, right. SPY, please. Suction. Okay. Now we switch to the SPY. Water.
No SPY image on the screen. Can I have SPY image on the screen?
IT, please SPY. Nggak muncul SPY-nya.
Nggak connect itu sama tuh. Di sana yang merah-merah tuh.
SPY, please.
Itu yang merah sana.
Di luar kayaknya. Dokter Ainun, SPY glassnya tidak kelihatan, Dek. Wait a minute. Seems like the spyglass disconnect. Okay. Okay.
Good.
I think the spy, you can see, sorry.
Yes. And
Can I remove the wire?
Yeah, remove the wire.
Okay.
And replace with the laser fiber.
Yeah. Yeah. I think this is the stone on the left side.
Right.
Water. Water. Yeah. When the water inject, I think the stone will go far to the proximal.
Okay, good.
Water. I think the tip of the laser. Yeah. Huh? It's resistance for the laser.
If you listen, pull back spine scope a little bit and more advanced, and put scope more.
Okay.
And slowly advance, yes. It's better or not?
Still resist.
Okay, pull back again and put scope down.
Pull back the.
You can see the follow. The follow is the distant area is at the tip of the ESP scope.
Okay.
Yeah, pull back the spine scope and put in.
I think it's inside.
Okay, it's coming. Good. And then readjust the spine scope.
Oh my God, it's out. Sorry. It's
okay,
out.
no problem.
It's out. Oh, sorry.
Okay. You can freehand cannulation, no problem.
Yeah, freehand cannulation. I will stop first. Okay. Insert the scope inside. I think here it is.
The endo view fishing.
Endo view. Oh, sorry. Okay.
Not moving. Endoscopic view. Yes, scope view, not fishing.
IT, please. The endo view is not. It's freezing.
Okay, good. Yeah, and then you move spine scope up.
Move
spine scope
up.
view up. Yeah.
Okay, it's fully up.
Endo view fishing again.
Here it is. Okay. It's entrance again, I think. Not yet. Okay.
Yes, we can go on. Yes.
Okay. It's in. It's in right now.
Be careful. Yeah, good. Very good. Yes. And then adjust the spine scope in the center. Yeah, you can see stone here.
Yeah.
Okay. And slowly advance the laser fiber.
Sudah dekat itu. Tuh.
Yeah, and then you adjust the spine scope to keep in the center. Yes, more to the left. Yes, good. And water allocation and set the laser system.
Okay, that's good.
Oh, that's good.
I'm trying with the 2 joule.
Yeah, two, at least two first, and then try again.
Maybe it's too close. Supporter. Okay. Okay.
Oh, sudah fragmented.
It's
More
fragmented.
advanced. Yeah, more advanced. Yes, yes.
More.
It is in, yeah.
Okay.
It's fragmented.
Yeah, you can see very effective, huh?
Yeah.
Maju sedikit, maju sedikit, maju sedikit. Okay.
You can see breaking. So already broken.
Yeah, it's break. Yeah, it's break.
Di bawah lagi. Di bawah lagi, di bawah. Ya. Ya. Action Dr. Luthfi. Action Dr. Luthfi.
Okay.
Ya, berarti. Ya, oke. Yes.
It's fragmented.
Yeah, quite good.
Okay. Tuh. Maju dikit. Ya. Kita kan.
Assistant may be aspirate at the allocation pot. Yes.
Okay, cukup dulu. Ayo.
How long maximally we can?
I think maybe half an hour you can finish in this particular case.
It's broken. It's broken.
You can see it's really good pigmented, right?
Okay.
Yeah.
Wait a minute. I will.
And you maybe insert spine a little bit deeper to see more stone clearly.
Jangan terlalu cepat.
Kenapa?
Nanti terus tiba-tiba habis 2 sampai 3 mili.
Okay.
Yeah, you can see all stone broken, right?
Yeah.
Basically, it's the end point you can pass the spine up to the hilum. That the end point that already cut, already broken.
I think the stone's still big.
Yeah, you can more, yeah.
Yeah. Yeah.
Insert scope deeper.
Wait a minute.
Stop.
Seems like the stop go out. The The scope is like out. Yeah, I think this is very good because the radiation is minimal.
Yes.
But the maximal biaya.
But the price is maximal. Prof. Thawee. Okay. Again. Try again.
But now,
Okay.
Yeah. Floro.
Scope, please.
Up.
Okay.
Be careful. Keep cock white. Keep cock white. Keep cock white. Yeah.
Keep
Lie lock.
Okay.
Yeah, lie lock cock white because to avoid slip out again. Yeah, good view. Yeah.
Gelas. Belok kiri, belok kanan. Ya. Ya.
Okay, adjust the spine scope. Be careful, very slowly. Okay. Use a lateral knob of the spine scope to manipulate. Yeah.
It's maximal.
Be careful. Put the scope in. If you slip again, put the scope in. Cock wide again. Be careful. Slip out. Yes. It's coming. Yes. Good. Yeah, and yeah, it's very good version right now. And you can start fire. You can see stand on the left hand side. 7 o'clock.
Later?
Yes. You can start fire. And then you slowly advance the scope in, really slowly advance the scope in to see the big stone, not the fragmented stone. Right now, pull back laser a little bit. Yeah, it's not much. And then put the scope in, adjust to see the big part of stone.
Okay.
Yes, and fire. Adjust some on up again. Yeah. Yeah, the good position. This is very good. Yeah, that's good.
Okay.
Yes, and then slowly advance and to break stone, slowly advance, break stone. Yeah, yes. You need to see stone. If you see stones, are more effective.
Yeah, very big stone.
And more advanced, stop and more advanced to see stone. And stop, 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 and pull back laser a little bit and more advanced to see more stone, more big stone. Yeah, yeah, on the right hand side.
Okay.
Yeah, the big past stone. Be careful the viaduct on the 12 o'clock. Be careful. Yes, yes, this better. On the left side better. Yes. Yes, this good area.
Ya, sudah betul. Ini
Bukan. Sebelah kanannya, Tuan. Yeah.
Put more scope inside. Insert scope more.
Ya.
More scope.
Ya. Oke.
Okay. Okay. Adjust to right side to see the stone on the right. Yes, this one. Yeah, this one and break. Yes. You need to see the fiber. Yeah, you need to see the fiber. Not too far. If too far, you cannot see the tip. Sometimes you cannot see the tip. Maybe the viaduct injury. You need to see the tip fiber scope. The fiber laser. This very important. Yes. Yeah, this good one.
Air. Betul. Jangan dulu. Ya. Oh, cukup.
So I think you can check with the cholangiogram.
Itu yang dipisahkan atau lupus sekarang adalah
Cholangiogram?
Yeah, you can check with cholangiogram by inject in the irrigation pot. If you want to check is adequate or not.
You see the flora?
Yes.
It's almost clear.
Yes. Can you magnify the follow? I cannot see clearly.
Flora, please. You see?
I think it's really good because this stone is a little opaque. Right now, no more. I think it may be enough.
Maybe enough.
Yeah, I think so. Maybe it's remove spy and use a balloon to check. And maybe they let at this time, maybe they let. Or you can a little bit more. Okay, you can a little bit more. Right now, I think it's the only fragment.
Only segment?
Yes, I think so.
Seems like that this is big. Check.
You can inject contrast in the election port to see the cholangiogram.
Yeah, pardon. On the.
You can inject the contrast in the election port.
Can we inject contrast here? Okay. Okay. We will inject the contrast.
In the election port, yeah.
Oh. Contrast inject.
You can see all stone fragmented.
Yeah, fragmented.
Yeah.
So no need more crushing.
Yeah, crushing. I think you can. I think you can remove spine and you dilate the ampulla, and then remove stone and remove stent.
Okay. This is fluoro. I will remove the fiber first.
Yeah, recannulate again with synchrotome.
Okay. Okay, fully back. The camera, please. Okay. Now, wisping first.
Yes. And then I'm not sure the cut or not, or just dilate with the CE balloon. Huh?
We have balloon dilator. What size?
In this particular case, normally I use 12-15.
12-15, okay. 12-15. Okay. Sping, just sping, yeah?
Yes.
Could you please marking the limit?
Do you have CE balloon?
No, yeah, balloon, but not yet balloon. First, I think we are precut sphincter.
No. Do you have CIE balloon? Do you have CIE balloon?
Balloon dilator?
Yes, CIE balloon dilator. Do you have?
Oh, yeah, we have.
Do you have 12-15 or not?
Yeah, I have 12-15.
Yeah. If you have CIE balloon 12-15, no need for dilate for sphincterotomy because already done. Just dilate with CIE balloon.
I just have 18-20. Maybe this is too big.
Oh, too big? No, not. If not available, you can cut more. I will show you the marker. You can cut more sphincter.
Show me the marker. The marker, please. Siapkan tandanya untuk itu. I have 10-12.
10-12 is okay. If you have 10-12.
Okay, 10-12. Okay. Pertahankan wire. Nggak apa-apa. Biarkan saya. Di mana saya? So I pull back the sphincterotomy, prepare for dilatation.
Yes.
With the size 10-12.
Yes.
Before, if I found the stone, big stone like this, sometimes I perform in many times, 4 times to clearly the stone. But I think right now with the SPY, one shoot can release all of the stone.
Yeah, I think it is very helpful.
Yeah. Yang berapa ini? 10-12. Oke. Punya.
Dr. Luthfi,
Ya.
in the BPJS view, several times will be better because the coverage is more than one time, but using spyglass.
Yeah.
Expensive, huh?
That's our national insurance. Yeah, it means that we perform 3 times, so the payment is 3 times too.
Yeah.
So, how's in Thailand, Prof? Prof Thawee?
Depend on the case. Normally, is if big stone, we also use spy to break.
Okay. How's the national insurance wisdom?
Mostly, national insurance not cover spy.
Ah. Better in Indonesia, they can cover, but a very small amount. So sometimes we are using. Oh. Wait a minute, Loro.
Yeah.
Okay.
Yeah.
Yang gue tarik cuman. Okay. Now the balloon insert. You see the balloon. Okay. Insert more. Okay. Dilate it, please.
Yes, dilate. Slowly. Because 10
Slowly
to 12.
dilate it.
Yeah, just start 10 first. TATM. 3 atmosphere first.
Oh, 10 first. 10 first.
Yes, 10 first. Really slowly.
10 mili dulu. 10 mili dulu. Berapa kali 10 mili? 3 at ATM. Slowly, 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 please.
Yeah, very slowly.
Okay.
Roughly is half to 1 minute, and then up to 5 ATM.
1 minute, and then
up to 5, and then to 8.
This is for 1 minute. Sometimes I do this for 2 to 3 minutes.
Yes.
Can you please explain to us about the maximal size of using?
The maximum size depend on the size of the bile duct. Roughly is if the size of the bile duct more than 14, 15, 16, normally we dilate up to 15. If you dilate more than 15, be careful, list of the perforation of bleeding, be careful.
How's 20? Do you have experience?
Of the beating?
20 mm.
No, I normally do not recommend 20. Please do not do it. Because our consensus from Asian consensus, more than 15 list of bleeding perforation. And all the fatal cases from 20 millimeter in diameter.
Sudah 8. Ya, sudah.
Belum.
8. 8, please. If the bleeding, what is the
normally is when you up in the patient, up to 8 ATM is 12 millimeter in diameter, and you deflate some small bleeding can happen, but not much.
Okay. Okay. Now it's 12.
Yes.
The size quite same with the scope.
1 minute, and then you deflate and use the balloon to remove stent and stone.
I think in the endoscopy view, you can see
the sphincter,
the lumen of the distal CVD bigger. Yeah. Yeah.
And then deflate, deflate, yeah.
Deflate. Slowly deflate.
Slowly, yes.
Yeah. You can see bleeding.
Some bleeding, yes.
Okay, I think it's fully.
And then keep the wire and put the balloon in.
The balloon, what kind of balloon?
Retriever balloon.
Retriever?
Yes. 15 millimeter diameter. 12 to 15.
12-15, ada tidak? Lagi? Retriever. Yang tadi. Ya, kasih masuk wire dalamnya. I think the bleeding is not so. Yeah, the bleeding is minimal.
Yes.
Can you explain the technique of using a balloon to remove the migrating stent?
The first one, you need to make sure the ampulla area is no stricture. The number 2, you put a balloon with sky wire up to the hilum, and you fully blow balloon at the hilum, and then pull back, sweep the balloon down. Mostly the stent will coming from the ampulla.
How's the risk of perforation in the distal?
So normally very less, except when you retrieve the balloon, the tip of the stent impacted in the distal bile duct. So you need to observe the tip.
Okay. Okay. Wire. Okay. Okay. So, firstly, I remove the stone or remove the plastic stent?
Plastic stent. You remove plastic stent and stone will coming. Put the wire up to the entire duct, and change to the balloon, yes. And balloon bowl.
Yeah. Oh no, we have to go to the right side.
I cannot see the follow view. Yes, both balloon.
Chlorophyll, please. IT, chlorophyll. You see right now?
Yes, bow balloon. Fully bow balloon.
Fully balloon.
Okay.
Balloon, full balloon.
Yeah. Okay.
Yeah, and pull back slowly. Pull back slowly. You can see stent moving. You can see stent moving. Yeah, right now stent outside. I think stent outside the ampulla.
No, yeah, right.
Yes, and then you deflate deflate and then remove stent first.
Wait a minute, belum, masih dia. I think still inside, yeah.
Slowly manipulate the tip, yeah. You can see on the 5 o'clock stent,
yeah.
And then you remove balloon and just use a
deflate balloon.
The left tooth to remove the stent first. Yeah, use left tooth to remove stent first.
Pakai apa? Snare atau apa? Jangan pakai crocodile. Snare or crocodile?
Crocodile. Left tooth.
Crocodile.
Snare difficult. Cross first, cross. Yeah. No. Cross first, cross. No, not open. Cross. No.
Tutup dulu. Buka man. Buka. Tutup.
Okay, open, fully open.
Oke. Tutup dulu ya.
Ya, di dalam.
Ya. Open.
Yes, open, fully open. Fully open.
Gigit.
And you see follow. Clap, cross.
Fully open. Ya, baik. Not yet. Buka.
Open. Nama oke naik.
Put the scope in a little bit, yeah.
Gigit.
Right. Close.
Yeah.
Yes. Tightly. And then pull back. If not, use balloon. You can see there. You can see stent, huh?
Yeah. Wait a minute. Okay, open. Right.
Good.
Oh.
Yes.
Good.
Put scope in.
Okay.
Yeah, put scope in. Oh, yeah.
Open.
Try again. Slowly. Yes. Yes, good.
Right.
Put scope in.
Yes.
Pull the scope in.
Yes. And then you can remove. Leave position again. Yeah. Readjust.
Bite. Fully bite.
Yeah.
And yeah, you can remove this scope. Huh?
Open. Bite.
Bite.
Okay.
Dari posisi.
Yeah, remove this scope first. Yes.
Mission complete.
Not yet. Ya, tutup. Tarik.
Hancur semua.
Okay. We go inside again.
Yes.
I suction the water first.
Yes.
To avoid aspiration.
Aspiration is very important. Yes, right.
Yeah. Okay. And then using balloon?
Yes.
Okay. Okay. Okay.
Don't like that. Don't look back, ya.
Yeah.
Tekan air ya, Ita.
Now we are inserting the balloon.
Okay. Okay.
To remove the fragmented stone.
Ini kontras ya? Kontras. Air. Kontras.
Wire, please.
Wire.
Wire.
Wire, oke. Kloro.
Oh, we are from the distal.
Yeah, from distal first. You inject contrast first to see the stone location
contrast
and the site.
Kloro. Wire-nya belum sampai ke atas tuh. Oke. Wire ke atas.
Keep the wire more inside. Yeah.
Okay, that's good.
Yeah, and then inject contrast.
Contrast.
One. Keluar lah sih karena saya ada balonnya.
More contrast, more. More contrast.
More satu. More contrast. Masih ada satu bak.
Yes, and put the balloon with and bow balloon and remove this stuff first. Bow balloon.
Yes. Okay. Balloon.
Balon. Full. Balon.
Yeah.
Yes.
Oh, very big.
Iya, ke atas.
Smaller. Yes.
Smaller. Okay.
This is kalau endoscopy view.
Smaller.
Ah, kempit itu
Lagi. Okay, I will insert again. Balloon. Okay. Oh. The side is.
Yes, push scope in and cock wide.
Yeah.
Incoming.
It's right. Okay.
Okay, and deflate.
Deflate balloon. We'll go in again.
Wire. Ya.
Yeah, it's fragmented stone.
Yeah, go in. Balloon.
Balloon.
Okay.
Okay, enough. Pull back slowly.
Yes.
Slowly. Yes. Okay, deflate.
Yes.
You can see stone.
Deflate.
Okay.
Okay, inflate. Okay, inflate.
Okay. Yeah, balloon.
Balloon.
Yes. Yes.
And decrease balloon a little bit, not much. Decrease a little bit.
Decrease.
Okay.
Yes.
Yeah, stone now. Okay, one more time. Inject contrast.
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 Balloon first and contrast.
Balloon.
Contrast.
Contrast again. Contrast. In. More. Contrast. More. Contrast. More. Contrast.
Okay, release. Deflate.
Balloon.
Okay. You put the balloon in the hilum.
In hilum. Okay.
Yeah, hilum.
It's
This area, yeah.
Hilus.
Put balloon in hilum, yeah.
Ke atas sana. Okay.
More up, more. Okay, balloon.
Tarik wire sedikit. Wire.
Ya, balloon.
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 And slowly pull back and contrast
Okay.
injection.
Contrast.
Slowly pull back, inject
Yeah,
contrast.
very slowly.
Okay, contrast. Contrast.
Contrast.
Pull back slowly.
Iya, dia selalu contrast. Okay.
Slowly. Yes, slowly. Very slowly. Yes, very slowly. Yes, very slowly.
More contrast.
Very slowly. Yeah.
Ambil gambar luar. Dokter, selalu saya tidak.
Yes.
Okay, contrast more.
Yes.
You cannot go out.
Yes. Decrease balloon a little bit. Decrease, not much. Follow. No, not much. Okay, put the balloon in. Okay, bow balloon. Okay, decrease balloon a little bit. Decrease, not much. Slowly. Okay, lock. And then you pull back the balloon tightly. Yes, and then put scope in. Okay, coming. Try again. One more time. Deflate balloon. Deflate balloon. Okay, follow.
Loro.
Okay, bow balloon. Yeah, bow balloon here. Yes. Okay, pull back and contrast. Yes, say I think it's good. And then pull back balloon. Tightly. Pull back. Follow. More. Pull back more. Back more. And you lock with your left hand and put scope in, cock way, and big wheel down. Yes.
The right side and cock down.
Yes.
Push. Okay.
Put in. Yes, they're coming. So I think you keep the Y and use the basket to irrigation, same as the second case. To remove
basket again.
Yes, small fragmented. Use a basket.
Basket.
Yeah, basket to irrigation.
Yang tadi yang simple basket.
Normally, it's every case that I break stone with the mechanical tipter or laser or ESL. Mostly, I use a basket to wash early case and suction to remove small remaining fragmented stone.
Okay, I'm using the trapezoid basket.
Water.
I pull back slowly until the ampulla. Yeah. It's freehand.
Yeah, big up, big up. Yes, big up, big up, big up. Yes, good, big up. Yes, yes. And follow. Okay, up, more, up more. Open the basket.
Open the basket. Open the basket. Okay, slowly, slowly.
Open the basket.
Open the basket. Yes.
And early cation with saline and pull back, checking and pull back slowly.
Saline.
And yeah.
NaCl, saline.
Yeah.
Air. Saline, NaCl.
And checking, pull back, suction. This is a final step.
Suction. Go back, suction. Go back, suction, irrigation.
How many times, Prof. Thawee?
Until the water come out clear, no any fragment of stone.
Until clear.
Until you can see the water coming out from the bile duct. It's really clear, no stone.
Water more.
You can see some stone coming here. You can see?
Yeah.
You can see stone coming.
Okay. Buka.
Ya, kasih pinjam lah itu. Ya, dari aja. Coba dari tadi. Coba dari tadi.
I think this is an important final step because if you use only balloon, some small fragment stone remaining.
Okay. Okay. We go in again.
Yes.
Open slowly.
Open slowly. Open. Yeah. Open slowly. Yes. Open full.
Okay. Water. Irrigation water.
Water.
And you can observe the ampulla. You can see the water come out. Yeah, and checking. Yeah. You can see some stone still coming. Yeah.
Yeah. Stop. I think good enough.
Yes.
You can finish.
Yes. Congratulations, Dr. Luthfi. Great team.
Yeah, thank you very much. Big applause. Yeah. Okay.
I think if you have a big stone, you can request tandem.
Yeah, right.
Yeah, for sure, Prof. Yeah, for sure. I always ready for support Dr. Luthfi.
Also move those Samalinda to Dr. Cinta as well.
Kemenhap, Professor. Thank you very much.
Yeah, Priya, Pak Tandang.
Yeah, Dr. Sinta as well, Prof. Yeah, always.
Okay, Alhamdulillah.
Prof. Thawee.
Yes.
I have a question.
Yes, please.
Yeah. In a case with a stone in the GB and also in the bile duct, like the second case of Dr. Nokman, you know,
Yes.
surgeon has a facility of cholangioscope. So you are a surgeon. So my question is it which one is more convenience? Like you do a one step, remove the stone from GB and directly also the bile duct, or you just do like this, you remove the stone in the bile duct first and then later in the GB. That's a two step, because I don't know how difficult to do.
Right now, motor center. Right now, motor center remove by SP first. Why? What the reason? The reason is if you open the bile duct, you need to put the T-tube. That's the drawback of the one step procedure. Right now, the most of centers still open the bile duct, put the T-tube. But one step is good in terms of the case that the big bile duct, for example, 2.53 cm bile duct, and the patient fit for surgery, really young, good candidate. At that time, surgeon to make a lap chole, remove stone, and make the bypass. So right now, I think it's a one step procedure. In the real world, less and less and less and less. Normally, it's use the ESP technology first.
Prof, I thought you don't need to open the bile duct. I mean, you just go through the GB cystic duct and then going to the bile duct. Not like that, Prof?
Depend on the case, because transitic approach is depend on the cystic size. Basically, cystic duct is 3 millimeter in diameter. It's small one. Difficult. But if imaging shows cystic duct big one, not difficult, but depend on the location of the stone as well. Sometimes the stone is high up in the hilum. Even you use transitic duct, you cannot remove stone. So I think lab surgery, you can do it, but in terms of difficulty, more compared with the ESP technique. So I think it's good alternative if ESP fail. That's a good option. So I think.
Okay, thank you, Prof.
At this situation, the surgeon need to really skillful for endoscopy as well, because technically more challenge, and you need cholangioscope. For example, Boston produced a short spicoscope called Spicas Discover. Spicas Discover like disposable cholangioscope. Also, this is one of the good options. Right now, our center, we also use this one for percutaneous.
Yeah, Prof. Thawee, and also from Boston, from Olympus, and also from the participant from many islands in Indonesia. Thank you very much for joining us in the first May Endos Makassar Espan. Especially for the accessory, just like the columboscope. I hope in the next time, Makassar will have many new equipment, just like spyglass or laser. This is all related to your supporting to us, service and other, and I hope we can meet you in the next time offline in Makassar in Thailand.
Yes, yes.
Thank you very much.
Yes, I think I also can congratulate Dr. Luthfi, team, Dr. Numens, nurses, resident, and also our friend from Indonesia, Cinta, in Malang, and also thanks Sumbo for arranging with this webinar. It's the live case. Thank you. Maybe see you in Indonesia or Thailand.
Yeah, Dr. Cinta, thank you too. Pak Tandang from Boston.
And
Thank
also thanks Thandan and Vilaypon for kind as well. Thank you.
Yeah, thank you everyone.
Thank you, Prof.
Thank you very much, Achan.
Thank you, Prof. Thawee.
Yeah. Bye
Don't
bye.
forget, I already booked you, Achan.
Yes, definitely.
No.